Hello, I'm João Lemos from Portugal. First of all, I would like to thank Interacoustics for having invited me to be here today. I'm going to give you an overview on eye movement disorders from a neurological perspective. I hope you enjoy the session. I have no disclosures. So as you will know, we have different classes of eye movements. We've got fast eye movements such as saccades. We've got slow eye movements such as pursuit and vergence. We have fixation, which enables us to fixate an object of interest. We have vestibular eye movements, which enables us to fixate such an object when moving our head. And we have optokinetic eye movements, which we're not going to address today. So importantly, for each type of eye movement, we have a specific network within the brain that is responsible for its execution. And all this information from these different networks will converge into the oculomotor nuclei in the brainstem, both for horizontal eye movements and for vertical eye movements. And this information most often arises at a cortical level. So, for instance, if you want to perform a saccade to the left, the right hemisphere will be activated and will send signals into the left brainstem to execute this movement. On the other hand, if we want to pursue an object to the left, in this case, the left hemisphere will be activated, and again, signs will be sent to the brainstem to execute this movement. This also works for vertical eye movements, but in this case, things get a little bit more complicated because it's believed that both hemispheres are working at the same time in order to perform vertical saccade and vertical pursuit. So the first type of eye movement disorders that I'm going to address are fixation disorders. Whenever fixation is unstable, we have saccadic intrusions. Of course, that these may be found in healthy individuals, but whenever these are very frequent and show large amplitude, they suggest that there's a neurological disorder going on either at cortical or basal ganglia brainstem or cerebellar level. So the most frequent type of saccadic intrusions are square wave jerks. In this case, this is a patient with Parkinson's disease, and as you can see, the eyes alternate between fixation, and then they lose fixation, and they came back to the fixation point again endlessly. And as you can see here, there are several forms of Parkinsonism, like PSP, MSA, and Parkinson's disease that can show square wave jerks, but also spinocerebellar ataxia type 3. And note that even healthy individuals can have square wave jerks. So unfortunately, they're not very specific for neurological disease, since healthy individuals can also have those. And you will see this a lot in your recordings. In contrast, if you see this, which are called microsaccadic oscillations, these are kind of a burst of square wave jerks. When you see this, you know there's a cerebellar disease and is affecting the fastigial nuclei. So this patient, for instance, has a recessive form of ataxia called Friedreich's ataxia. And interestingly, in Friedreich's ataxia, there's an associated vestibular impairment. So these patients classically show deficient head impulses. Another form of saccadic intrusion are saccadic pulses, which are kind of half square wave jerk. Again, if these are frequent, they might point and suggest the presence of a neurological disorder, in this case, the basal ganglia disorder. And they can also occur in spinocerebellar ataxia. And actually, we recently described it that they can occur alternately between eyes. So as you can see here, there's an inward movement of the eye, but it's alternating between the right and the left eye. We call this pinball intrusions, and again, these reflect cerebellar disease. In this case, this was seen in a patient with spinocerebellar ataxia type 3. Another saccadic intrusion, which is classic one. It's called ocular flutter. So in this case, this is a very fast, very quick saccadic intrusion because it lacks intersaccadic intervals. That's why it's so fast. And as you can see, it predominantly occurs at the horizontal, along the horizontal plane. And this is actually the definition of ocular flutter. So when this happens, one knows for sure there's cerebellar disease and that it's affecting the vestigial nuclei. And even more importantly than that, it points to a cause, to an etiology, to a specific etiology, since most of these patients will have a paraneoplastic disorder, and this often will be the first sign that that points to the presence of a tumor elsewhere in the body. And if you have an IC-cam, you can nicely show that not only patients have head flutter, but head flutter may actually propagate into other segments of the body, in this case to the head. So this patient not only has head flutter, ocular flutter, but he also has concomitant head flutter. And with IC-cam, we nicely show that these movements were simultaneously and occurring in the same direction. So this is head flutter. It's rare, but it can happen. Another rare event is to have a saccadic intrusion that can be only precipitated by head position. So in positional testing, you might precipitate a saccadic intrusion. So this patient had multiple sclerosis, and she had a new episode of vertigo that was mild left feeding nystagmus in the seated position. But once she lay down, we could precipitate a very strong positional ocular flutter, indicating in this case a new demyelinating lesion in the middle cerebellar peduncle. It's rare, but again, it might occur when performing positional testing in patients. Finally, the last one, opsoclonus, is very similar to ocular flutter in the sense that also points to a cerebellar paraneoplastic disorder. But in this case, the saccadic intrusion is multidirectional, showing not only an horizontal but also a vertical and torsional component. So it's very important to have a recording method that records all these three planes at the same time in order to make a correct diagnosis. So in resume, basal ganglia and cerebellar disorders are among the most frequent kind of disorders that can cause frequent and large, very fast saccadic intrusions. The other type of eye movement disorders that I wanted to talk to you about are saccadic disorders. So saccades are fast eye movements that direct our gaze into an object of interest. And when impaired, these can be slow in pontine and midbrain lesions. And the brainstem can be hypermetric, meaning that they undershoot the target in cerebellar and basal ganglia lesions. Can be hypermetric, meaning that they overshoot the target in cerebellar lesions. Can be delayed, meaning that there's a delay in their initiation. Here we are usually talking about cortical and subcortical disorders, including dementia. And there are several types of disorders that can affect saccades, including degenerative diseases, stroke, metabolic, inflammatory and toxic disorders. As I briefly mentioned before, there's a cortical network responsible for generating saccades, including that comprises the frontal eye field, the parietal eye field, etc. All this information is carried, transported through different pathways to the brainstem, but before that, is further calibrated and modulated by the basal ganglia, cerebellum, and the thalamus. And once reached the brainstem, specifically the oculomotor nuclei, then the subject will be able to perform a saccade. So the most important properties of saccades are latency, amplitude, and velocity. And overall, When we have a cortical problem, we can have a latency problem. When we have a basal ganglia or cerebellar problem, usually we're talking about that this will promote an amplitude problem. And when we have a brainstem problem, then velocity of saccades will be probably impaired. So the first disturbance that I wanted to show you are slow vertical saccades. When this happens, you know you have a midbrain problem affecting the rostral interstitial nucleus of the medial longitudinal fasciculus in the midbrain. There are several disorders that can give you this type of abnormality, including a very specific form of Parkinsonism called progressive supranuclear palsy. Often there will be a mismatch between saccades and other types of eye movements. So these patients might not be able to perform voluntary fast eye movements called saccades, but if we tilt their head in a forward and backward fashion, they'll be able to do a visually enhanced VOR along the vertical plane. So this means that although saccades might be impaired, the vestibular system might be spared, at least in the initial stages of the disease. So there's, as you can see here, when telling the patient to look up and look down, he's not able to do that. But when moving his hand while he's fixating an object, then we can actually see a nice visually enhanced VOR movement. Then we have slow horizontal saccades. In this case, the problem is in the pons, in the specific structure called pyramidal pontine reticular formation. Slow horizontal saccades are not as frequent as vertical, slow vertical saccades, but they might occur in Gaucher disease, etc., some rare disorders. And then one should not forget about torsional saccades. So when we have a unilateral midbrain lesion, we can have selectively impaired saccades, torsional saccades, to the side of the lesion. That's what we're seeing here. Patient has no torsional saccades to the right, but is able to have those to the left. And this is because this patient has a right midbrain lesion. And if we do a torsional VOR, we are able to see the fixating compensatory torsional saccades only to one side. So this is a nice way of putting in evidence the unilateral midbrain lesion. So the right midbrain is responsible for rightward torsional saccade. The left midbrain is responsible for generating left torsional saccades. Then we can have hypermetric saccades. It's a straightforward phenomenon telling us that we have a cerebellar problem and generative ataxias and so on. And then we can have hypermetric saccades. In this case, they undershoot the target, and this might be due either to a basal ganglia disorder like Parkinson's disease or a cerebellar disorder like degenerative ataxia. And then we have a rare phenomenon called lateral pulsion of saccades. In this case, these might occur in pica strokes, so vestibular strokes, where saccades to the left, in this case, are hypometric, but to the right, these are hypermetric. So as you can see here, they're hypermetric to the right and hypometric to the left. If you see this, you might have a medullary medulla oblongata lesion, and this sometimes occurs in pica strokes, and so it's a very powerful sign in terms of localization. So this is the right pica stroke, giving you this type of saccadic abnormality, and you can also have this abnormality along the vertical plane. So hypermetric saccades and looking up, in hypermetric saccades when looking down. This often occurs in degenerative ataxia. So hypermetric saccades up and hypermetric saccades when looking down. So again, lateral pulsion of saccades. Saccades can also be delayed, as I told you, and this usually happens in cortical dementias like cortical basal degeneration, etc., where there's a severe delay, more than 500, 600 milliseconds delay in initiating the saccade. So it's not a brainstem problem, it's a cortical problem, and usually it occurs in dementia. And nowadays, not only is it important to perform pro-saccade, as I'm performing here, but even more important is to perform anti-saccade. So saccade directed in the opposite direction of the target, and these are considered to be a measure of cognitive function, specifically frontal lobe function. And this is a very important to have it in your recordings as well, because this, for instance, is correlates very well with the frequency of falls and imbalance in several disorders, such as Parkinson's disease. So saccades mainly are, normality of saccades are mainly caused by cortical problems, cerebellar problems, basal ganglia problems. So ocular pursuit can also be usually by a cortical, brainstem, or cerebellar lesion. Importantly, also aging, drugs, inattention, and fatigue can also get it. And in all these conditions, is usually omnidirectionally impaired, meaning that both horizontal and vertical pursuit is impaired. So the only time I think a pursuit of normality is useful from a clinical perspective is when it's unidirectionally impaired, either to the right or to the left, up or down. That's what we're seeing here. So only to the left, you can see decomposed pursuit. To the right, it's rather smooth. This indicated a right vestibular nucleus lesion. By the same token, in this patient, pursuit is only impaired when pursuing down. And in this case, we should think about superimposed downbeat nystagmus and clearly indicating that we have a cerebellar problem in this case. So I only have this to talk about pursuit because, again, unfortunately, it is very unspecific and it does not have a very localizing value when evaluating patients. I will only briefly mention Vergence disorders as well. So whenever we have a Vergence disorder, the patient is not able either to converge and or diverge his eyes. And this can be associated with neurological disease. And importantly, patients may show simultaneous vestibular impairment and Vergence impairment as well, as in the cases that I'm going to show you next. So this patient had upbeat spontaneous nystagmus, but you can see that the eyes are both deviated inwards, so we had convergence strabismus. Acute convergence strabismus, until proven otherwise, is due to a midbrain lesion like this patient had. We have convergence excess. And note that I'm performing alternate cover test. So this is an important issue. Alternate cover test in vestibular patients is not only to diagnose vertical strabismus like speed deviation, but it's also very useful to diagnose horizontal strabismus like in Vergence disorders. And this patient had convergent strabismus associated with midbrain disease. This other patient had a convergent with traction strabismus, which again indicates a midbrain problem that is affecting the Vergence network in the brainstem. This is rather rare, but it may occur. So you can see that there's an inward deviation of the eyes that is somehow paroxysmal. And finally, patients with spinocerebellar ataxia can also and frequently show convergent strabismus and not only complain of progressive imbalance due to ataxia and to bilateral vestibulopathy, but they also complain of diplopia. This is a patient with spinocerebellar ataxia type 3 that classically shows convergent strabismus at far when looking at distance. And these patients also classically show bilateral vestibular impairment, as you can see in the heading pose test. And importantly, convergent strabismus in this case is nicely correlates with imbalance in this patient. Then we have vestibular disorders, and we all know that when there's vestibular symmetry, often we will have nystagmus. In central disorders, you will have downbeat nystagmus, cerebellar disease, upbeat nystagmus, mostly in brainstem disease, torsional nystagmus, also in brainstem disease, usually indicating a lesion of the median longitudinal fasciculus and some other structures, including the vestibular nuclei and interstitial nucleus of Cortical. And so there's a myriad of disorders causing nystagmus, as you can imagine. Cerebellar degeneration, stroke, metabolic causes, Wernicke's encephalopathy, multiple sclerosis, tumors, etc. So again, just a quick reminder: downbeat nystagmus is caused by floccular disease in the cerebellum most of the times. Upbeat nystagmus is due to either a pontomesencephalic or a medulla oblongata lesion. Torsional nystagmus is due to a lesion of the medial longitudinal fasciculus and or lesion of the interstitial nucleus of Cortical or the vestibular nuclei, and horizontal nystagmus, which is clearly the one that is most challenging when trying to differentiate between a peripheral and central disorder, is mostly caused by either a floccular lesion or a vestibular nucleus lesion in the central nervous system. So starting with horizontal nystagmus, usually we are talking about a floccular lesion or vestibular nuclear lesion. And like in this case, this patient had a pike stroke, and there's left feeding nystagmus in normal heading pose test. That's what you're seeing here, and the VHIT, the normal or almost normal heading pose test. Then we have central torsional nystagmus, and this one usually is associated with the internuclear ophthalmic lesion and with skew deviation, because all these abnormalities reflect an impairment of the same structure, specifically the medial longitudinal fasciculus. So in this patient, you can see a mild right torsional nystagmus, especially in the right eye. Note that this kind of nystagmus is usually dissociated, so it's mostly torsional in the right eye, and it's more an upbeat type of nystagmus in the left eye. So it's often dissociated between eyes. And then we have downbeat nystagmus that most of the time reflects a chronic degenerative ataxia or some metabolic impairment in the cerebellum at the floccular level, creating an asymmetry between the downward and the upward vestibular pathways in the brainstem, ultimately causing downbeat nystagmus. Note that downbeat nystagmus might be very, very mild in mid-gaze, but then when you tell the patient to look to either side, it becomes more evident. Like in this case, this patient has canvas. So we now have a genetic cause, a specific genetic impairment for canvas syndrome. And another important notion is that downbeat nystagmus can be treated with several types of drugs, including aminopyridine. So you can see in the upper segment there was more downbeat than in the lower segment when after 4 hours of aminopyridine intake. So we have drugs that can improve nystagmus. So it's very important to detect it and correctly diagnose it. Then we have upbeat nystagmus that most of the time reflects a brainstem disorder, and is a classic presentation of Vergence encephalopathy, so thiamine deficit causing an acute upbeat nystagmus. And again, it reflects an asymmetry between upward and downward pathways and vestibular pathways in the brainstem. And in this patient with thiamine deficit, you can see spontaneous upbeat nystagmus. And what you'll see next often occurs is that when we ask her to follow our finger and convert her eyes, the upbeat transforms into downbeat nystagmus. And in Vergence patients, this is often the case. And additionally, when we ask her to look to either side, you can see that the upbeat nystagmus is abated, and now we start to see downbeat nystagmus. So this transition between upbeat and downbeat in thiamine deficit patients is quite characteristic and points towards the diagnosis. Then we have rarer forms of nystagmus or simple nystagmus like periodic alternating nystagmus. In this case, it reflects a highly deinnervated vestibular nuclear complex because the nodulus and uvula in the cerebellum are no longer inhibiting the velocity storage mechanism in the vestibular nuclei. So here, basically, the eyes beat to the right for some time and then start to beat to the opposite side. That's what we're going to see next. So beating to the right, stop, and now start beating to the left. This patient had a cerebellar inflammatory disorder, cerebellitis, and that was treated with anti-inflammatory drugs, and this was gone after a few months. So this is periodic alternating nystagmus. It's rare. Sometimes it's more evident in the dark, but should be correctly diagnosed. And importantly, there are drugs that can specifically treat it, like in the upper segments, we can see the leftward and the rightward phase of the nystagmus, and in the lower segment after baclofen, you can see it's gone. We only see square wave germs. So it's treatable, and we should diagnose it. Another rare form of nystagmus is seesaw nystagmus. In this case, usually we have an interruption of vision. So there's usually a chiasmal problem interrupting vision and further calibration of eye movements by the cerebellum. So these patients usually have bitemporal amyotropia, loss of vision in their temporal eye fields. And so in this case, the eyes will, one eye will move up and toward, the other eye will move down and extort. This is extremely rare, but points towards a chiasmal lesion and is associated with a visual problem. Then this one everybody knows. This is gaze-devoked nystagmus, and it's caused because the gaze integrator system in the brainstem is no longer working, or the cerebellum. And then we're talking about a lesion in the vestibular nuclei, in the flocculus, or in the interstitial nucleus of Cajal. And in this case, patients will show eccentric nystagmus. So when looking into an eccentric position, you will have nystagmus either to the right or to the left or up or down. In this case, this patient had degenerative ataxia. Another rare form of nystagmus due to disruption of the visual fixation is pendular nystagmus. Of course, there are cases where it's congenital, but I'm talking here about acquired pendular nystagmus. And one of the most common causes is multiple sclerosis when affecting a very specific area in the medulla oblongata called paramedian tract. And in this case, patients will show a complex form of nystagmus with both torsional, vertical, and horizontal components. And importantly, nystagmus is dissociated between eyes And actually, the eye with more loss of vision, usually due to optic neuritis, is the one that shows larger components of nystagmus. So, and this one is very disabling because it gives oscillopsia, because it's somehow fast and with large amplitude. So, and for detecting and correctly diagnosing this type of nystagmus, you need a recording system that allows for simultaneous recording of horizontal, vertical, and particularly torsional eye movements. Another similar form of nystagmus, a pendular nystagmus, is oculomotor tremor. In this case, it is usually a result of a stroke, of a previous stroke in the brainstem, in a specific region called Mollaret's triangle. And whenever we have oculomotor tremor, usually we have a pendular form of nystagmus, and sometimes it's so mild. Note the conjunctival vessels, and you can see a very tiny pendular torsional nystagmus. And when you see this, you look at the palate, and you will see synchronous movements of the soft palate. So having the same frequency of the torsional pendular nystagmus that you saw before. And again, this form of nystagmus sometimes is very mild, is clearly associated with progressive ataxia. And again, it's very important to have a system that can record torsional eye movements. And like in this nice example, this patient had progressive imbalance, and we did detect pendular torsional nystagmus, which is often associated, which often is a manifestation of oculomotor tremor, so it indicates a lesion in the location that I mentioned before. And note in this segment that the horizontal recording just showed a few square wave jerks. Vertical recording was completely normal, but then the torsional recording, we can see pendular movements, which were clearly associated with the pendular torsional nystagmus in this case. And again, it's important to diagnose it because we have treatments for this kind of rare nystagmus, including momentum. So this was before momentum, and this was after momentum. And as you can clearly see, there was a reduction in the amplitude of eye movements after momentum in this patient. We now finish with internuclear disorders, starting with internuclear ophthalmoplegia, which is a paralysis of adduction in one eye and the presence of abducting gaze-evoked nystagmus on the other eye. It indicates lesion of the medial longitudinal fasciculus, which is a tract that connects the 6 oculomotor nucleus on one side with the 3rd oculomotor nucleus on the other side, and is usually caused by either the myelinating or vascular lesion. So here you see right eye node. So there's a mild paresis of abduction in one eye, the right eye in this case, and there's gaze-evoked nystagmus, which is common in the left eye. So this is the right eye node indicating a lesion of the right MLF, as I'm depicting here. MLF not only carries saccadic signals, but it also transports vestibular signals, in this case from the left posterior and anterior semicircular canals, and from the left ventricle. And it mostly carries signals from the posterior canals. So whenever we have a patient that we suspect that has an internuclear ophthalmoplegia, it's very useful to perform 6-canal VHIT, because what you're going to see is that the right posterior, left anterior are showing a normal function, but the left posterior is deficient and shows a low gain on VHIT. So a right INO is strongly associated with an impaired function of the contralateral posterior canal on head impulse. So a deficient posterior canal is not only a manifestation of, let's say, a posterior vestibular neuritis, inferior vestibular neuritis, but it often occurs in central nervous system disease affecting the medial longitudinal fasciculus. So this is a patient with right INO. You have a left posterior hypofunction. And this is a patient with bilateral INO, meaning that has affection of both medial longitudinal fasciculus, and as expected, both posterior canal VHIT is impaired. And then this is a patient with myasthenia, which gives rise to strabismus and sometimes mimics conditions such as internuclear ophthalmoplegia. So this is not a lesion of the NLF, and therefore the posterior canal related VHIT is normal. So VHIT can help differentiating between different forms of strabismus. And importantly, the nuclear ophthalmoplegia can also be improved with medication, including the use of aminopteridines, dalfenpridine in this case. And finally, I'm just going to briefly mention, I'm just going to talk a little bit about skew deviation, which is a vertical misalignment caused by an asymmetric or unilateral disruption of the vestibular pathways carrying signals from the vertical semicircle canals and otoliths. And so both the vestibular nucleus, MLF, interstitial nucleus epiphyseal, or dentate nucleus lesion can cause skew deviation. Note that also peripheral vestibular disorders can give rise to a skew deviation, although in this case it's usually milder. So here you have just a scheme to show that a skew deviation can be caused by a lesion of the MLF, interstitial nucleus epiphyseal, vestibular nucleus, and importantly, even in peripheral vestibular lesions, because the latter are also affecting the pathways carrying signals from the vertical semicircle canals and ventricle. And when you have skew deviation, you have one eye going up when intorting, the other eye going down, and extorting. You have vertical strabismus, one eye up, the other eye down, and you have a tilt of the subjective visual vertical as well. So this is a patient with skew. So the left eye is hypertrophic, meaning that is the eye in an upper position, relatively upper position. And in this case, there was a lemmic and midbrain left lesion. And this was this retinography. So see that the hypertrophic eye was extorting, and the hypertrophic eye, so the eye in the upper position, was intorting, which is a classic sign of skew deviation. So this is the patient that you saw before. Not only she had a right internuclear ophthalmoplegia, right torsional nystagmus, but she also had a skew deviation, which is usually in the side of the internuclear ophthalmoplegia. So a right internuclear ophthalmoplegia is associated with a skew, where the hypertrophic eye is on the side of the internuclear ophthalmoplegia. And see the internuclear ophthalmoplegia as well. So one eye is not able to abduct the right eye, and the left eye is showing gaze devoked nystagmus. And this is a patient with vestibular neuritis. He was also complaining of diplopia. Usually it's mild diplopia, but they might have a mild form of skew deviation. So we have a left vestibular neuritis, and some of these patients might complain of diplopia. Finally, this is the last patient. So she has an inflammatory form of ataxia, and she has downbeat on spontaneous gaze, but no vertical misalignment. But when she looks to either side, you can now see that one eye is going up, the other eye is going down. The left eye is going down, the right eye is going up, going down, going up. And so there's vertical misalignment, not on spontaneous gaze, on mid gaze, but on lateral sides. And this is very common in patients with chronic cerebellar disorders. And now the eye in an upper position changes. Now it's the right eye, which is in an upper position, and the left eye in a lower position. So this is alternating skew deviation, and it commonly occurs in chronic cerebellar disorders. So alternate cover test in vestibular patients should be done not only in spontaneous in mid position, but also in to either side in order to detect alternating skew deviation. Okay, this is what I wanted to show you. We're now open for questions. Thank you.